Hey everyone, and welcome. Today we're kicking off a brand new series for all you healthcare professionals and students out there. And we're jumping into something that's honestly a huge deal, mastering the art and science of deprescribing for our older patients. So let's get right into it.
So I want to start with this question because it really gets to the heart of what we're talking about today. Medications obviously are incredible solutions. But in geriatrics, where a patient might have a whole list of conditions, that line between solution and problem can get, well, pretty blurry. The very thing we prescribe to help can sometimes become the problem itself.
First, we'll nail down the problem. What are the triggers to look for? Then we'll get a clear definition of what deprescribing actually is. After that, we'll explore a great framework to guide our thinking, walk through some practical steps, and finally open up the toolbox to see what instruments can help us out. It's a clear path from problem to solution.
Okay, first up, the problem. We have to talk about the clinical triggers. See, before we can even begin to talk about a fix, we have to get really good at spotting the signals, the signs that tell us a change might be needed. So what are those clinical situations that should just make us pause and ask, hey, is it time to think about deprescribing here?
And here they are, 4 of the biggest red flags. You've got your adverse drug reactions, of course, and polypharmacy. That's just a huge issue when a patient is on way too many medications. Then there's something called a prescribing cascade. That's when you prescribe a new drug just to treat the side effects of another drug you already prescribed. And finally, and this is so important, we have to rethink everything at the end of life in palliative care when the whole goal shifts from preventing things down the road to focusing on comfort right now.
All right, so we've got a handle on the problem. Now let's flip the script and talk about the solution. It's time to properly define the hero of our story, the process of deprescribing. What does this word really mean?
Okay, this definition is so important. Deprescribing isn't just randomly stopping meds. Let's unpack this. It's an organized process. That means it's systematic, it's thoughtful, and it's supervised by a professional. And here's the best part. It has a goal of improving specific outcomes that are tied directly to the patient's own goals of care. See? That changes everything. It's not just an action, it's a deeply patient-centered way of providing care. Now, with something this complex, you can't just wing it. You need a framework, right? A mental model to kind of hang your thoughts on, a way to make sure you're looking at the whole person. And that is exactly where the 5 M's framework comes in. And here it is, the 5 M's of geriatric care. You've got mind, mobility, medications, multi-complexity, and what matters most. Just look at that. Medications is just one slice of the pie. It's part of a much bigger interconnected puzzle. You can't possibly make a good decision about a medication without thinking about how it affects their mind, their ability to move, their other complex issues, and above all, what actually matters to them.
Okay, so the theory is great. We've got the why, we've got the framework, but how do we actually do this? Let's get down to brass tacks. This next section is all about the how. What are the concrete, actionable steps we can take in the clinic or at the bedside?
Here's a really solid 5-step approach you could literally use tomorrow. First, you do a deep dive, a comprehensive medication review. Then you assess the risks of every single drug. Step 3 is so important. You have to prioritize. Which meds should go first? Maybe the one with the highest risk or the least benefit. Then you actually discontinue, tapering down if you need to. And finally, and you can't skip this, you have to monitor them closely for outcomes and for any withdrawal symptoms.
And this is maybe the most important part. This idea is woven into every single one of those steps. This is not some top-down thing we do to patients. It's a partnership we do with them. And the research is pretty clear on this. Most patients are more than willing, sometimes they're even eager, to stop a medication if we just talk to them about it and include them in the decision.
Okay, so we have a process. But the great news is you're not out there on your own trying to figure this all out from scratch. There's a whole toolbox filled with validated instruments that were designed to help us make these complex decisions.
So basically, these tools come in 2 main flavors, implicit and explicit. Think of it this way. Implicit tools are like guides. They help frame your clinical judgment by asking the right questions. Explicit tools are more like a checklist. They are criteria-based lists of medications you should probably avoid in certain people or situations.
And this table does a great job of laying them out. On the implicit judgment-based side, you've got things like the Medication Appropriateness Index, or MAI. And on the explicit, criteria-based side, you have the big ones you've probably heard of, like the AGS-Beers criteria or the STOP criteria. They each have a different strength, a different role to play.
But here's the thing, it's a big one. These tools, these criteria, they're fantastic guides, but they are not a substitute for your clinical judgment. Ever. And this is especially true in geriatrics, where, let's be honest, the evidence for a lot of common medications is still a bit murky or is constantly evolving.
Let's take statins for primary prevention. Perfect example. This one study from 2020 found that in veterans over 75, taking a statin was actually linked to a lower risk of death. So, case closed, right? Everyone gets a statin. Well, not so fast. Look what the researchers themselves said right in their conclusion. Further research is needed. The story is never that simple.
Okay, now check this out. Another study from the exact same year came to a much more nuanced conclusion. It found that in healthy adults over 70, sure, statins might help prevent disability and heart disease, but they were not beneficial for prolonging disability-free survival or for avoiding death or dementia. This right here, this is that gray area. This is where you have to go beyond the data and have a real conversation with the patient about their goals.
So after all that, what's the big takeaway? Where do we land? It's actually really simple, and it's powerful. Deprescribing is not some optional extra credit task. It is a core competency. If you want to provide excellent geriatric care, you have to be just as skilled at thoughtfully and safely taking medications away as you are at prescribing. And that really leaves us with this final, crucial question to think about. We've got the frameworks, we have the tools. So the real challenge is, how do we overcome all the barriers? And there are a lot of them, from the way our systems are set up to our own habits and even patient fears, to make this a reality for every single patient who could benefit.